Good morning, everyone. Today, it's my great pleasure to introduce our speaker, Dr. Daniel Burkhoff. Dr. Burkhoff obtained his MD PhD from the Johns Hopkins School of Medicine, where he also completed his fellowship in cardiology. He then moved to Columbia University, where I actually had an honor and pleasure to meet him and attend many of his hemodynamic lectures and also follow him on rounds. He was brought to Columbia and established and ran the Cardiovascular Research Laboratory through 2003, and then took the position of the director of the Jack Skirball Center for Cardiovascular Research of the Cardiovascular Research Foundation through 2005. His focus then shifted to the development and research of medical devices of several startup companies where he served as the medical director, looking into diagnostics and therapies for heart failure. He then returned to CRF as the director of heart failure, hemodynamics, and MCS. And he also now directs their educational program that is called TEACH, Training and Education in Advanced Cardiovascular Hemodynamics. Dr. Burkhoff's interests include cardiovascular modeling, research in basic and clinical aspects of ventricular mechanics, cardiovascular monitoring, heart failure, and MCS. He's also the author of Harvey, which is an interactive simulation-based application, which is available worldwide. So Dr. Burkhoff's nickname is the king of PV loops and hemodynamics. He's also the author of multiple publications and had multiple lectures at all the possible national and international meetings. So we're really excited to have him today as our speaker. Welcome, Dan. Thank you so much for doing it, and enjoy the lecture.
Thanks so much, Kasia, for inviting me. And yeah, let's talk about PV loops a little bit. Maybe bring a lot of people back to medical school and see how PV loops can be fun. I'm going to be talking about the pathophysiology of shock, cardiogenic shock, and the effects of different forms of mechanical support. It may be that some of you have seen parts of this lecture, but I keep try to update it with new information. And I always hear that it takes a couple times to hear this anyway to kind of get the full breadth of the appreciation for what we have to say here. These are some relevant disclosures, and I believe that you've received these learning objectives, which I won't go through. I wanted to just start this with a case that was sent to me by my friend Manreet Kanwar. This was a patient that was being referred to her from an outside hospital, and you can see on the angiogram on the left here, the distal, very tight left main stenosis, multiple lesions at the bifurcations. Patient was in shock and was crashed onto ECMO, and she was sent this echo from the outside hospital. And she asked the physicians if they would be able to vent the ventricle, and the response was, why should we put an impella in? We already have the patient on ECMO, so why do we need to put in oops, can you hear me?
Yes, we can hear you. It seems to be breaking up a bit. So I think if you leave your video off, that should help with the bandwidth issue, as I know you're in a hotel and using their Wi-Fi.
So she said, basically, they asked why should we put a vent in, or an impella to vent this patient. Here, clearly you can see the smoke in the left atrium, and the mitral valve not even opening here hardly. And then so they questioned why we need a vent, and then a few hours later she got this image where there's already starting to be thrombus forming in the atrium and inside the ventricle. So these kinds of images continue to appear. This is a very recent case, just a few weeks ago, and I think that it speaks to the need for us to continue our quest to inform people and educate people about the benefits of understanding the physiology of shock and devices. So I will be talking about this physiology within the context of the pressure volume loop. This is the normal loop. which is basically a rectangle that starts in end diastole. You've got the 4 phases of the cardiac cycle, which form the rectangle of the normal pressure volume loop. The valves open and close at the corners. And also the loop sits on the end diastolic pressure volume relationship and hits at end systole the end systolic pressure volume relationship. And where the loop sits and how wide it is and how tall it is dependent on the preload and the afterload. The width of the loop is the stroke volume, and the height of the loop is basically the pressure generation. And the pressure at the bottom right is the end diastolic pressure, which of course is tightly related to the pulmonary capillary wedge pressure that the lung is experiencing. In terms of preload, what is preload? Preload is when you change the end diastolic volume or the end diastolic pressure. You see that as we increase preload, the heart generates more pressure and more stroke volume, but the loops always fall within these 2 boundaries of end systolic and end diastolic pressure volume relationships. It shows what happens when you change just afterload. The loop, if you increase afterload progressively, the loop will get taller, meaning it's generating more pressure, but at the expense of a reduction in stroke volume. So this is what happens with increased afterload. When contractility changes, the slope of the end systolic pressure volume relationship will change. And so going to a decrease in contractility, you see that there will be a decrease in pressure generation and a decrease in stroke volume, whereas when you increase contractility, you'll have an increase in pressure generation and an increase in stroke volume. Now, with regard to the physiology or the pathophysiology of cardiogenic shock, I'm sure that you've all come across this very famous diagram from Judith Hochman, who led the initial shock trial that outlined the basic pathophysiology of shock, which starts with a primary insult to the myocardium that results in a decrease in LV, RV, or both ventricular contractilities. This results in reductions in blood pressure, reductions in cardiac output. CVP and wedge pressure may increase, decrease, or stay the same, and I'll talk a lot about that in a minute. And with the hypoperfusion and hypotension, there's acidemia, there's a decreased coronary perfusion, and that leads to worsening ischemia, and that kind of feeds this whole process. But as secondary effects of these primary hemodynamic factors, there's activation of the baroreceptors, and this happens very rapidly. This causes at least at a minimum 3 things, which are increase in heart rate, increase in SVR, and venoconstriction, which increases the stress blood volume, which is the effective circulating blood volume. And now if this situation persists longer term, it leads to an inflammatory response, systemic inflammatory response, vasodilation, and multi-organ failure. So this is what we're trying to counteract. So there is time plays an important factor here about whether you're in a vasoconstricted state or whether you're in a inflammatory vasodilated state. Now, let's consider first the physiology of isolated left ventricular failure. So here we have LV and RV pressure volume loops. And what you can see is if we decrease only left ventricular contractility, we've got the reduction in the end systolic pressure volume relationship on the left. That results in the reduction in blood pressure and cardiac output. And that activation of the baroreceptors, you see the loop is going around quicker. The SVR is increasing. And also the increase in stress blood volume will result primarily in an increase in the pulmonary capillary wedge pressure. CVP may be the same, may be increased with isolated LV pressure, but regardless of what happens to CVP, you can see that there are marked changes in the RV loops because the increase in the wedge pressure is actually contributing significantly to an increase in RV afterload, and the loop, you have the generation of pulmonary hypertension even without a change in the pulmonary vascular resistance. Now, RV failure, isolated RV failure is a little different. Here you have a reduction in the RV contractility, and what that leads to is underfilling of the LV, And it's that underfilling that results in the decrease in cardiac output and blood pressure. But you have that same activation of heart rate, SVR, and stress blood volume. In this case, though, you have a primary increase in the central venous pressure, and wedge pressure and end-diastolic pressure can actually be decreased. So life is not so simple as having pure LV or RV failure, and more typically, whether it's an MI or decompensated heart failure, there's involvement of both ventricles. And so here things get a lot more complicated in terms of what's happening with this interaction, this serial interaction between the right and left ventricles. There's parallel interventricular interactions that cause extra problems. And again, we have these and there's a greater variability in what happens with CVP and wedge pressure. So let me first talk about wedge pressure and central venous pressure, or RA pressure. And these are data from the Cardiogenic Shock Working Group. And what we've done is we've taken these the data from patients with right heart cath data available, and we plotted the RAP versus the wedge pressure. And we've divided this plane into 4 different quadrants. The lower left is when wedge and RAP are both normal, and we kind of call that the euvolemic quadrant. Elevated wedge pressure with normal RA pressure is cases where there is kind of isolated left-sided congestion. The bottom right is when CVP is elevated, but wedge is normal, and that is right-sided congestion. And on the top right is when you have RA and wedge pressure elevations, and this is when you have bilateral congestion. And in this series, as you can see, fully 50% of patients have a bilateral congestion profile. And only 25% or so have isolated left-sided congestion, and another 20% are in kind of the euvolemic state. And the bottom right, only about 10% present with isolated right-sided congestion. So this is the profile, but this congestion profile has important implications for prognosis. And here what you see is the overall mortality in this cohort as a function of which quadrant the patient was in. And you see that if the patient was either euvolemic or had isolated elevation of wedge pressure, their mortality was about half that as whether compared to whether if the patient was in had right-sided primary congestion or bilateral congestion. So this elevation of CVP is playing a very major role in the prognosis of patients who present with shock. So while we're very aggressive in treating wedge pressure because it obviously creates pulmonary edema, difficulty with oxygenation, and patients feeling the feeling of shortness of breath, and requires intubation often, we less frequently deal with the elevation of CVP. But it's really that elevation of CVP that is contributing quite a lot to the prognosis. And that's independent of whether the patient presented with a shock due to myocardial infarction in green here, or to decompensated heart failure shock. The other thing that we can see here is the trend that patients who present with AMI have a worse prognosis than patients who present with shock with heart failure. So that's also a theme that's evolving in the literature, that we know that even when you account for other factors such as cardiac power output or lactate, patients who present with heart failure, decompensated heart failure shock, have a lower mortality than those with an ischemic or acute myocardial etiology. So let's now turn to, with that as a background, let's turn now to therapies and talk a little bit about inotropes, pressors, and then various devices. And one key point that I want to emphasize is that when you talk about what is the effect of a device or a drug, it's really not possible to say that any therapy always does a certain thing. And the response, the hemodynamic response anyway, to either a drug or a device can be extremely variable across the different patient profiles. And that is because, especially when we talk about devices, the hemodynamic response really depends highly on a number of factors. So for example, the degree of LV and RV compromise, which we've just talked about, plays a big role in the response to a device. Short-term recoverability of RV or LV function. So is this a acute fulminant myocarditis where whatever you do, in the short term, the contractility of the RV and LV are not going to improve? Or is it a case of ischemia where improving perfusion and reperfusion will result in a gradual improvement in either RV or LV function? SVR and PVR, volume status, MRTR, background medical therapy, all of these things impact the response. So what we can do though, in using the simulations like the Harvey simulator, is we can kind of level the playing field and say, okay, let's just look at it at a particular condition, and we can compare the effects of various device and therapeutic effects. So let's look at a few examples. So this shows the physiology of inotropes and pressors. So right here, we're giving a combination of an inotrope and a pressor. And what you can see is the inotrope increases the contractility, the end systolic pressure volume relationship. That results in an increase in the pressure generation in the stroke volume and cardiac output, of course. And you can maybe appreciate that the ball is going around a little quicker, because inotropes and pressors have also the effect of increasing heart rate. That's kind of a consequence, kind of a side effect, if you will, of those drugs. Now, the other part we want to talk about and consider in some of these therapies is what's happening to myocardial oxygen consumption, which is down here at the bottom. And what we've done here is we've plotted the relationship between MVO2 and the total work that the heart is doing, which is indexed by this parameter called the pressure volume area. And the pressure volume area is the sum of the stroke work, which is the area inside of the loop, plus the area to the left of the loop. That whole area is what correlates with oxygen consumption. And what you can see is when you use inotropes and pressors, not only does the pressure volume area increase, which is the leftward shift here of that point, but also this relationship increases, it raises, so that at any, due to the increase in heart rate and myocardial contractility at any given work, the heart will use more oxygen consumption. So all of these things, the increased contractility, the increased work, the increased heart rate, are all conspiring to increase the myocardial oxygen consumption, which can be very detrimental to myocardial viability, especially in the setting of acute myocardial infarction and ischemia. We know from preclinical models that inotropes and pressors can actually increase infarct size, and therefore that can contribute to worse outcomes in these patients. So let's talk a little bit now about balloon pumps. And I won't go through the hemodynamics other than to say that it's just for the sake of time, I'm not going to go through detail in the hemodynamics of balloon pump, but just to say that the randomized trials have shown that balloon pumping does not improve outcomes and really does not, in the short term, does not really significantly impact on the hemodynamics of patients in cardiogenic shock. That is, these studies were done in patients with acute MI shock. And I'm sure you're all aware of this results of these studies, the IABP Shock 2 study, which really had a big impact on the impact of the use of balloon pumps, especially in Europe where this was done, and to a large extent here in the US, where people have started to question more and more the utility of balloon pumping in AMI shock. So failure of balloon pumping has encouraged the further development and utilization of mechanical support. And I'm really going to just focus on ECMO and the Impella, the percutaneous ventricular assist devices. So let's review the physiology of ECMO first and understand why some patients actually, the ECMO can lead to loading of the heart and also thrombus formation within the ventricle. And it's really shown here. With ECMO, when you initiate ECMO flow, the goal is to increase the arterial pressure and improve perfusion of the body, which is what you're seeing here. The blood pressure has increased. But with ECMO, the only way for blood to get out of the heart is for the ventricle itself to overcome the new increase in pressure. And with a heart that's very weak, that won't happen until the preload in the heart is increased such that by the Starling mechanism, it can generate that new required pressure to eject the residual venous return. And this is really why ECMO can induce LV load, an increase in end diastolic pressure, which of course, again, relates to an increase in the wedge pressure, can lead to LV distension. And you see here that the stroke volume is very low, and that means very small amount of aortic valve opening, which fosters aortic valve stasis within the ventricle, the left atrium, and even in the aortic root. So there's not a lot of human data about the hemodynamics, but here's some animal data. And basically, this is an animal model of acute profound heart failure, shock. And basically, you kind of read this backwards. This is baseline, and going back from right to left is increasing the flow of the ECMO. And what you could see is, first of all, the end diastolic volume. So this is LV volume. Volume is increasing, just like I showed you. Aortic pressure, of course, is increasing. CVP decreases, which is a good thing. But we basically have this loading of the ventricle, progressive increase in LV volume and the distension. And all the while this is happening, of course, the wedge pressure is also increasing. So here's another animal study that shows pressure volume loops at baseline during shock. You see the end systolic pressure volume relationship is blunted. And then during ECMO, and here you could see there's this persistence of a very high end diastolic pressure. And also the ventricle cannot overcome the new increase in pressure. And in fact, this ventricle is way overloaded and is not even able to open the aortic valve. These are isovolumic contractions. So that's what that looks like on the pressure volume diagram as shown in an animal model of acute shock. Of course, the related phenomena are the Harlequin syndrome or the north-south syndrome. Here you see an aortogram of a patient on ECMO, and clearly the dye is really not reaching the inferior part of the body, just going to and fro and staying in the thoracic aorta. That means that the superior part of the body is being perfused from the heart. And if that valve is, clearly the valve is opening here, if that heart is in pulmonary edema, if the lungs are in pulmonary edema, and the heart could be ejecting here deoxygenated blood, while the lower portion of the body is being perfused with oxygenated blood from the ECMO machine. This is a worse situation where you see, in fact, the aortic valve is closed. So while the whole body is receiving blood, you see streaming from below, the whole body is receiving oxygenated blood. We're now in a very compromised state as far as the heart is concerned. The heart's distended. This will clearly lead, there's no outflow, so the heart will distend, the wedge pressure will rise, and stasis in the ventricle can lead to thrombosis. Here's another example, clinical example. All these things kind of go hand in hand, is the generation of pulmonary edema, heart distension. See, the heart is dilated. You see the smoke in the LA and the LV. And of course, you see then that leads to thrombus formation inside the chambers. And there are dramatic examples in the literature now about the LVs being completely thrombosed. Here you see complete LV and atrial thrombosis. Here you see large thrombi forming across the mitral valve. And here's just another example of what this looks like on an echo of a patient where the aortic valve is completely snapped shut. And you can appreciate that this can lead to thrombosis, not only in the ventricle, in the atrium, but also in the aortic root. From the energetic perspective, it's important to note that although the stroke volume can be decreased with ECMO, it's not the stroke work that determines the myocardial oxygen consumption, it's the entire pressure volume area. So that LV distension can lead to, that LV distension will lead to also an increase in the myocardial oxygen demand, which of course, again, is not going to be helpful in the setting, especially of the AMI, when myocardial oxygen supply is limited. Now, as we know, not every patient who gets ECMO becomes loaded. The aortic valve, does not close in every patient that's put on ECMO. And as I mentioned, not every patient responds in the same way. So let's explore a different case here of a patient, a simulated patient, where the patient has actually left ventricular contractile reserve, meaning that once you put the patient on ECMO, let's say the coronary flow improves, the oxygenation improves, the pH improves, and the contractility can be improved. And here what you see is a different story, in that the heart, the end diastolic pressure really does not change very much. So this could be an example of a case where the patient does not go into pulmonary edema and perhaps does not require a venting strategy. So this just emphasizes, this is just one example, one fact illustrating just one factor that contributes to the variability of response to a therapy. And it emphasizes the point that when you're treating a patient with a mechanical support, it's many of the people now in the field that are kind of leading the charge on the development and the algorithms for how to treat patients in shock really encourage the use of invasive hemodynamic monitoring, specifically a right heart cath, so that you can really accurately and follow the hemodynamic response and the hemodynamic profile in real time, so that you can respond appropriately and know whether, for example, in ECMO, whether a patient needs or does not need a venting strategy. Now, in contrast, let's talk about ventricular assist devices, the physiology. And here you see a very, very different response. And this is because of several factors, the primary factors being that a ventricular assist device will directly pull blood from the ventricle to the aorta and directly unload the ventricle. The unloading of the ventricle results in a reduction in end diastolic pressure, so the wedge pressure goes down. It results in a reduction in the pressure volume area, so the myocardial oxygen consumption goes down. And you'll notice the change in the shape of the loop from rectangle to triangle. And that's because with a continuous flow device, you're continually pulling blood out of the ventricle so that the volume trajectory is always decreasing, except for a brief period of time when the mitral valve opens and you have some filling. So this is the mechanics of percutaneous ventricular assist. In the time domain, on the pressure curves, you could see that there's also the possibility of a phenomenon referred to as LV aortic pressure uncoupling. Obviously, normally when the aortic valve, when the ventricle ejects, aortic and ventricular pressures are the same. But if you flow a lot of flow, a high flow rate with a ventricular assist device, the aortic pressure will be increased while the LV pressure decreases. So you can wind up in a situation with a closed aortic valve. But unlike with ECMO, where that results in stasis, where a closed aortic valve results in stasis in the ventricle and the aorta, when you're using a ventricular assist device, you maintain flow both within the ventricle, the atrium, and also the aortic root. So the risk of thrombosis is really not a factor. These are real loops. They're measured from a patient on a Impella 5.0. You see without the Impella support, you see this rectangular or trapezoidal shape. And with Impella support on the right, you've got these triangular shapes that I've just been showing you. This is the other arm of that animal study I showed you. The bottom was the ECMO that I showed you. And at the top here now is the Impella arm. And again, you can see in the left, you see the normal loop. In the middle, the shock state. And then on the right is the Impella. And again, here now you can see the loop changing to a triangle from these small upright rectangles. So now we have a triangular shape, a loop, because of the physiology of continuous mechanical continuous flow from the mechanical device. Energetically, also, I've already implied that the loop shifts leftwards, so the pressure volume area shifts leftwards, and that has an effect of reducing the myocardial oxygen consumption. So these devices not only unload the heart from a hemodynamic perspective, but also from a metabolic perspective. Now, just as the response to ECMO varies from patient to patient, so too will it with using a ventricular assist device. And here we see that same patient I simulated before, where there was contractile reserve due to an improvement in coronary flow. And here we see the same exact phenomenon, that when we initiate flow, we improve the aortic pressure, we improve myocardial perfusion, in this case of ischemia, and the contractility is improved. And in the case of a ventricular assist device, we see that actually the heart and the device work together kind of even better in concert with each other. And the degree of unloading that you can get from in a patient with that has contractile reserve with an LVAD is even greater than if the contractile reserve was absent. So these the heart, and in the case of the percutaneous VAD, the device and the heart work together to achieve even better unloading. So what about the physiology then of LV decompression during ECMO? Well, there are many strategies for unloading the ventricle. There are at least 8 that that I think are in use, including, first of all, reducing the ECMO speed, use of inotropes, afterload reduction, use of balloon pump, atrial septostomy, combining an ECMO with a tandem heart, using a surgical vent, or combining an LV, combining ECMO with Impella, so-called ECPella. And interesting, there's a unique physiology to each of these approaches. Each approach may have its particular advantage in certain clinical scenarios, and each of them also would have a limitation. So I think it's important to be aware of all of these approaches, and in particular when they would be ideal to use, and maybe more important, when they would be either contraindicated or less ideal. I think the one approach that is extremely common now is the ECPella approach, combining ECMO with a Impella, and this shows the physiology of that combination. We start out with the loop here on the way right, which is the loaded ventricle, the ventricle that you're concerned about, that's been loaded. And when you apply a percutaneous assist device, you see that you completely counteract that loading effect. On the pressure time domain, what you see is now you've got 2 pumps that are working in parallel. And in this simulation, I've got both the ECMO and the Impella working kind of at, let's say, full speed. So we've got a lot of flow, and that means that you can generate a lot of pressure. So one of the advantages of combining ECMO and Impella, especially nowadays, if you choose a 5.0 or a 5.5 Impella, is that you can wean, that device is is sufficient of mechanical, hemodynamic, provides sufficient hemodynamic support so that you can wean and provide full support to the body. Once you've satisfied the oxygenation needs by ECMO, you can start weaning the ECMO, and also provided, of course, that the RV contractility is sufficient to support the flow of the body. So again, the choice of device combination and the ability to wean, and the strategy for how much of the flow is from the ECMO and how much of the flow is from the LVAD is very complex and depends on many factors. Again, speaking to the need or the advantages, let's say, of using continuous hemodynamic monitoring with a pulmonary artery catheter, so that you can customize the strategy to match the needs of the patient. This is an example of a real patient who presented with a wedge of 40, was crashed onto ECMO, and it was obviously in pulmonary edema, hypoxemic, acidotic, was crashed onto ECMO. The wedge pressure increased further. Patient was put onto Impella, and you see this very rapid and very profound reduction in wedge pressure, which totally this was an Impella CP, totally counteracted the loading. And by the way, you don't need a huge amount of flow to accomplish the unloading part of the ECMO of the heart while on ECMO. Usually flows between 1 and 2 and 3 liters are sufficient to achieve the unloading component, which suggests that in the earlier days, even an Impella 2.5 was sufficient to unload the ventricle during ECMO. But the issue there is if you think about your strategy on the other end of decannulation, it's not possible unless there's significant, or typically not possible unless there's significant recovery, to wean ECMO off to an Impella 2.5. And that's really where the choice of device comes in. If your strategy is going to be to wean the patient off of the ECMO onto a ventricular assist, and then ultimately off Impella in that sequence, then the strategy that most clinicians use now is to pick a larger Impella, either a CP or a 5.0. Some additional limited human data. This is a series of, I think it's around 30 patients that were put on ECMO, and then they were all put on Impella. So these are paired data. And if you look at the wedge pressure, there was about a 10 millimeter reduction. These are Impella CPs, a 10 millimeter reduction on average of the pulmonary wedge pressure. And of course, that also is associated with a reduction in the mean PA pressure as well. So this reduces markedly the afterload on the RV, which will help RV function. So there's multiple benefits, of course, of using this strategy. So that is a very quick review of a lot of complex hemodynamics and physiology. I think some of the take-home messages are that understanding cardiac physiology in the framework of the pressure volume domain helps to explain the hemodynamics of shock and therapeutics. And we did take somewhat of a deeper dive into ECMO and to percutaneous ventricular assist devices. I think one of the key messages that I reiterated multiple times was that the response to device therapies varies significantly among patients. And that is really, I think that in and of itself justifies the need to hemodynamically monitor these patients to tailor the therapy. Percutaneous VADs directly unload the LV while decreasing the wedge pressure and increasing blood flow to the body, whereas VA ECMO has the potential to increase the load on the LV and reduce aortic valve opening, which leads to stasis and can lead to thrombosis in both the LV, the aortic root, and also in the atrium. And there are at least 8 approaches to LV unloading in that setting. And I think it's important to know the advantages and the limitations of each of these. So that's what I wanted to cover briefly. I think I stayed within the time frame that I was asked to stay in, and I will be happy to answer any questions.
Thank you so much, Dan, for this wonderful lecture. Again, I think I know PV loops now, and probably I won't in 30 minutes, but you always make me feel that way. So this is awesome. Before we go to questions, I really wanted to thank our sponsors today, AstraZeneca and Alnylam. Thank you for helping us with this event. And we can take some questions.
Dan, thanks. Great talk, and nice refresher from all the way back to my fellowship. My question for you is, given your profound understanding of these hemodynamics, what are we currently missing in either a mechanical armamentarium or a pharmacologic to improve the care of these shock patients? There must be an opportunity out there.
Yeah, I mean, I think what we've seen over the last 5 years in particular is people are chipping away at mortality. And I think, at least in registry studies, it seems that mortality is being reduced. Some of the things that we've seen, like in the cardiogenic shock working group, is that in patients who are monitored with a pulmonary artery catheter, the mortality is significantly reduced. Now that's completely in a registry. It's not, we can't actually give a reason for that. But it may be just that when, in centers where pulmonary catheters are used, there's more attention being paid to the details of more fine tuning of diuretics and devices, so that we get wedge pressure and CVPs into better range. I think maybe there's better use, more prolific, a more proliferated use of some of these mechanical circulatory support devices. I think, as I mentioned at the very beginning, maybe one of the biggest opportunities is really attacking the CVP, and really going after that more aggressively. So, is it justified? I think it's justified to study. I'm not sure it's necessarily justified for clinical use, but I asked the question as a hypothesis, is it justified, to use more right ventricular assist to address the central venous pressure, or maybe to be more aggressive with diuresis in these patients, or renal replacement therapy, something to really to address that congestion on the right side, which we know leads to bad renal function, kidney function, liver function, and also contributes to the systemic inflammatory response due to bowel contributing to bowel edema and ischemia. So that's kind of one thing that's kind of glaring us in the face. It's just a glaring thing that CVP has such an important impact on prognosis. That's potentially one target. Of course, on the device side, the quest is always for more powerful devices that can be used with less adverse events. And this is really the, where I think industry continues to focus. Things like the ECP, I don't know if you've heard of the ECP, it's a device, it's an Impella that is put in at a smaller French size and expands. That's the E stands for expandable. Can expand to a larger French size once inserted into the body, so that it can pump more with a smaller insertion French size. More meticulous care of adverse events like groin access, vascular access, and also paying more attention to the factors that lead to hemolysis during MCS use. For example, typically the Impella, if it's not in the right place, can lead to hemolysis. But when there's careful attention to the positioning of where the outflow is with echo and/or fluoroscopy, and using the position, the motor current as a guide for positioning, making sure that outflow is not at the level of the aortic valve, will lead to less adverse events related to adverse events related to hemolysis. So I think the tools continue to improve. I think hypothesis that more aggressive hemodynamic monitoring helps to fine tune, the care, and maybe more aggressive attention to elevated CVP. Those seem to be things where are quote unquote low hanging fruit. Now, proving any of those things in clinical trials is really difficult, and that's really the main problem, is proving things in shock through randomized trials requires a Herculean task. We haven't had a randomized study in the US since the 90s, which was the shock trial, which was a very small trial. And by the way, the primary result of the shock trial was negative. The shock trial original primary endpoint was at 30 days, and the p-value did not reach statistical significance. I think it was a p-value of 0.1. Yet the trends that we're seeing, and the later the observation of that over the 6-month period, the p-values became more significant. I think that resulted in our adoption of urgent revascularization. So advancing this field through randomized trials is very, very challenging. That's why many of us have really promoted greater understanding of the physiology and the hemodynamics. And until we have more data to drive clinical practice, in level 1A evidence, to be guided by hemodynamics and physiology.
And thanks so much for this great talk. I want to know if you'd comment in the setting of ST elevation myocardial infarction and this concept of door to unload, such as it placing an Impella at the time of acute MI and then actually unloading the ventricle for 30 minutes before performing primary PCI, if you think there's a lot of utility in that.
Right. So first of all, that strategy is really for AMI without cardiogenic shock. I'll answer just in the context of shock first. To say one more thing that we talk about a lot is in shock, the time factor is very critical. As when a patient presents in shock, if you're at the bedside and the patient goes into shock at that instant, you're dealing with a primary hemodynamic problem. And as time goes by and the patient persists in a shock state, that you are moving progressively into that inflammatory state and moving from a hemodynamic problem to a hemometabolic problem and inflammatory problem. So in shock, time really matters, and no one is promoting this, delayed revascularization in the setting of shock. We just don't have enough evidence at this point for this strategy. But in the setting of AMI without shock, there's data from the 1990s. Robert Smalling was the first to show that he used a device called the hemopump, which is a earlier version, let's say, or a predecessor of the Impella. It was a slightly different principle, but same idea. He showed that with the hemopump, if you pump in an animal experiment, if you start your pumping during the period of ischemia prior to reperfusion, you will markedly reduce infarct size. That was then followed several years later, still in the 90s, by studies done by Bart Mains in Belgium with an Impella showing the exact same thing. That if you initiate pumping prior to reperfusion, that you will markedly reduce infarct size, markedly. You will also, he showed that if you pump at the time of reperfusion, you'll still reduce infarct size, but the benefit is markedly diminished if you initiate pumping after reperfusion. So that then led, that motivated Naveen Kapoor, who really went much further into the science of this unloading during ischemia, and started this whole development of the science of unloading, what happens at the molecular level and the cellular level when you unload during ischemia. And he showed that there are activation of multiple protective pathways, cellular protective pathways that protect the myocytes from dying, preservation of mitochondrial function, and again, activation of these anti-apoptotic signaling pathways. And that's what led to the pilot trial, the door to unload pilot trial, which purpose was to show safety and feasibility, which it did. It also showed that even despite delaying by 30 minutes the reperfusion, you still reached a 90-minute door to balloon time, door to reperfusion time, and also showed in patients with the larger infarcts that there was a significant trend for a reduction in infarct size. So I think that all of that has led credence to the hypothesis that this can actually be beneficial in patients. So while, as you all know, mortality in AMI without shock is quite low, there still is quite a significant incidence of heart failure following MI, and the incidence of heart failure following MI all links with the infarct size. So there is credence now to test this hypothesis, and it is being, as you all know, tested now in a large, fully powered randomized study. And it will take some time for these results to come out, but this would be an interesting transformative strategy, to reduce infarct size, which has been a quest, for 30, 40 years, we've been trying to reduce infarct size. And the only thing that has worked, obviously, so far is reperfusion. So this has the potential to, to take us to the next level.
Dan, I have a question for you about PA unloading during ECMO. So as you I'm sure know, there's this initiative, it's mainly led by Dr. LaRusso in Europe, that you can prevent LV distension by solely unloading the PA during the ECMO run. How do you feel about that? And what are your thoughts about it?
Well, I have a couple thoughts, which are obviously one of the goals of unloading is to reduce the return. Obviously you're trying to reduce the venous return to the left ventricle. So that's fine. I have no problem with that part. The question is whether you can really fully eliminate return to the ventricle, because you still have Thebesian drainage, blood coming, that's Thebesian drainage is obviously coronary venous blood returning directly into the chamber through the wall of the ventricle. You've also got return of the bronchial circulation. The bronchial circulation returns obviously to the left atrium and can contribute. And potentially, you have still you have the potential still for aortic valve closure. So if you unload the LV this way, and even if you reverse flow through the lungs, which is possible, I don't know if he's talked about that. You can show that you can reverse flow through the lungs, and by taking out oxygenated blood, you can from the pulmonary artery. Even if you do that, you still can have a closed aortic valve and stasis in the ventricle and in the aorta. So I think they're fighting two battles. One is decompression and the other is stasis. So I'm still skeptical that is in the end going to be a good strategy for all patients. I think you need to have the aortic valve opening so that you avoid those problems. I'd like to hear your thoughts about it.
I'm only going to say I agree with you. I actually 100% agree. And I think we underappreciate, the degree of the drainage directly into the LV and LA. So we don't think about it. And we actually see it, in the clinical setting a lot. And this is actually when sometimes we need to switch, ECMO, even with the, vent to like a BiVAP, for example.
Right. Yeah.
So great. And yeah, we have another question.
Thank you very much for the excellent talk. You earlier on delineated based on hemodynamics, different types of cardiogenic shock, being it euvolemic, RV isolated, LV isolated, and biventricular. Do you think selecting your therapies based on that, and by therapies I mean mechanical MCS particularly, is beneficial? And do you guys actually do that in practice?
Right. So in an expanded version of this talk, what I actually show is so you have that quadrant, that plot of CVP versus wedge, and what your strategy, I think, should be to somehow thinking about getting the patient to that normal CVP, normal wedge. I think we can probably agree on that's a good goal. The problem is that, and I think that's the goal, and I think the way to track this is to, and I think about this in my mind. I see where, I think about where a patient is, and then you choose an initial strategy. And typically, if you're, whichever strategy you pick, some people are ECMO first and some people are Impella first. So I don't want to get into that discussion, but you pick a strategy, you implement it, and you see where you are and you react quickly. If you go ECMO first and you see your CVP going down, but your wedge going up, then you add an unloading strategy and you track it. And if you don't reach your goal, you use another, you add another component, which is it to increase diuresis? Is it to add renal replacement therapy? Those are the kind of questions I think that arise. I don't think that if you're in biventricular congestion, you need to go to a biventricular strategy at the start, because as you know, in many patients, the elevated CVP and the RV dysfunction can simply be from the elevated wedge pressure. And when you decompress the left side, you markedly afterload reduce the RV, and the RV can start working again. And so I don't think that it's necessary to jump initially to a biventricular strategy if you're in that quadrant, but I think it's important to monitor where you are and stage your approach. The other thing I would comment on is you frequently hear that ECMO is a biventricular strategy, a biventricular support strategy, which in my opinion, it is not. It is a heart bypass strategy. It's a bypass strategy. And even in biventricular failure, obviously you can get the CVP down, but the LV is still subject to that afterloading problem, and the wedge pressure can go up and the LV can be distended. So I don't know how, I'd be interested to hear Cassia response, but I do not, I teach and at least promote, let's say, that ECMO is not a biventricular support strategy. And people think, well, it's similar to what they do cardiopulmonary bypass, but there's a huge difference between cardiopulmonary bypass and ECMO, which is that cardiopulmonary bypass, they have a reservoir and they put the patient on bypass and they drain the volume. That's the ultimate form of RRT, renal replacement therapy. They drain the volume into the reservoir, and that's very effective in reducing both wedge and CVP. Anyway, that's my response, is really to be guided by hemodynamics to achieve the goal. In essence, what the interventionalists used to call goal-directed therapy, goal-directed therapy, which kind of was in favor. I think it's out of favor now because it didn't pan out. But I think have hemodynamic goals in mind and monitor and shoot for those goals.
And I do agree with you again. Looks like you caught me well, but I do think it also depends where the patient is at that particular moment, right? I mean, is it a cardiac arrest patient? You know, what else is happening with the patient?
Sure.
I think, in my opinion, you cannot go wrong with ECMO, but you need to stage immediately, right? So to save patients' life, you're going to put them on ECMO, but then what do you do next, right?
Yeah.
Do you drain? And I think this other example of you need to have some flow through the lungs as well, right? So sometimes you actually may need to reach for biventricular support. I think that's pretty common, and common. It happens in post-cardiotomy shock. You put them on ECMO and you put a drain in and nothing's draining, you know, because there's no flow to the lungs.
Yep.
So, yeah, so that kind of would be, you know, but in my opinion, also it depends on, you know, what you're proficient at, right? Like some centers are very proficient, you know, at ECMO, like we're very kind of an ECMO-centric, center. But I think we do recognize, you know, when to unload and do all those other.
Yeah, absolutely. I mean, look, it's such a complicated factor. A complicated shock, you know, is so complicated. And in fact, I had right now I'm at the CRT meeting in Washington, DC, and there was a great session on Saturday about shock and, you know, all these things being discussed. But I got into a side discussion with some other, you know, people that are really involved at the front line. And I'm concerned that we actually cannot have a positive study in cardiogenic, a randomized study in cardiogenic shock. You know, and I'm concerned that, you know, look, we had the IABP shock 2 study, which was negative. And that's the easiest thing to do, is to design a negative study. It's very, very hard to design a positive study. And when you have a positive study, it's usually because you have a very narrow inclusion criteria. You're really trying to enroll a homogeneous population. And as you know, everything that we've talked about during this discussion tells us that the shock population is exceedingly heterogeneous. So even when you get a negative study, people don't follow the results because they don't apply to my patient. So I'm getting concerned that we need a different strategy to develop 1A evidence. This is going to sound this is going to sound like an oxymoron, but, you know, to develop 1A evidence without randomized trials. But the shock is so variable. I'm just concerned that we're spending all this time trying to do randomized studies when we need a more clever way to use data from registries. That's a little bit of editorializing and kind of, you know, we're going to have the next study that's going to report out is the danger shock from Europe. All these studies are being done in Europe because of the issue of informed consent, where they have a different method that's more readily available to them. We have that mechanism here. We're designing now the Recover 4 study, which is a randomized study of Impella versus standard of care, and it will take us about probably 18 months to go through the IRBs to activate this waiver of informed consent. It's not actually a waiver, but, you know, it's kind of a way of performing research in emergent situations that does not require full upfront informed consent. It's a very complicated, you know, working with the FDA. So the next study that will report out really is the danger shock trial, and then there's an ECMO shock being done in Germany. Those studies will probably report out in the next 2 years. So we'll have to see.
Thank you very much, Dr. Burkhoff. I know we are at time, but we do have one online question. Would you be willing to take just one more question?
Sure.
All right, so this question comes from Dr. Peter Ekman, and Dr. Ekman asks, by PV loops in physiology, we would expect Impella to be a great modality, even without ECMO. Why do you think trials have failed to show clear benefit to Impella alone?
Thank you, Peter, and hello to you. Great to hear from you. So the studies that have been, the randomized studies that have been done so far are limited in number. We're in the range of like 50 patients. And one of the studies, the IMPRESS study, most of the patients succumbed to, I think 80% had anoxic brain damage. So, these were early attempts in Europe to, to do these studies, which, they did not reach their enrollment goals. They stopped, all these studies stopped early because they couldn't enroll. They were going on for years and years. And the bottom line is that the danger shock is the study that is properly powered. It's powered to include 360 patients. It's been going on for 6 years so far. They have enrolled 260 patients. I don't know the exact number, but in the mid 200s. They've got another 100 to 150 patients to enroll. They're adding more sites in Germany. They think they'll have another 1 to 2 years for enrollment. There has just not been the direct answer to the question is there's not been an appropriately powered study. And obviously you can't make a conclusion from 50 patients of which, 3/4 died from anoxic brain damage due to, out of hospital cardiac arrest.
All right, well, thank you very much for joining us. I think that's all the time that we have for today. We really appreciate your time. And to all of our attendees, thank you for joining, and we will see you next week.
Thank you very much.